Hello and welcome back. Today we're here with the magnificent Dr. Kristi Funk. Thank you so much for being here.
Thanks for having me.
So you are a renowned breast surgeon, co-founder of the Pink Lotus Breast Center in Los Angeles with your husband Andy, and have helped and continue to help thousands of women through breast cancer treatments, including celebs like Angelina, Jolie, and Sheryl. To start off, please tell us a little bit about your journey in becoming whole food plant-based, Pink Lotus, and your book, Breast, the Owner's Manual, which I actually listened to on Audible. So yes, please, let's dive in.
All right, so my journey began in medicine way back at Stanford. So I was at the end of my sophomore year studying for a final. I was majoring at the time in psychology and had my sights set on combining drama and psychology to create like a psychotherapy practice for children coping with trauma or recovery from illness. That had just been my idea. I thought I made it up, but it turns out that psychodrama was a real thing. But I didn't know that, and I didn't either at the time. I thought it was my own idea. However, God had different plans, because apparently when I was studying for this final, it was a neuropsychology final, to date the hardest test I had ever taken in my life. And that class was taught by this wild professor who had a missing middle finger because a monkey named Kiki had bitten it off.
Stop.
And I was always fixated on his hand when he was talking. I digress. So this final's so hard, and I'm pulling my first all-nighter in my whole life, studying for it. So whether it was the caffeine or the all-nighter, but that was the moment where a thought overtook my mind. It wasn't audible, but it was clear, and it simply said, "You're going to be a doctor."
Wow.
And I was like, that's interesting. Incorrect, but interesting. And I would try to focus again, and you're going to be a doctor. To this day, I woke up my roommate. We were in like the artsy part of Stanford because I did a lot of drama, and she was a singer and still is a singer to this day. I woke her up. I'm like, "Michelle, I'm going to be a doctor." And she was like, "Okay."
Yeah. You were so on fire about it.
So that summer, I had already planned to be a short-term missionary in Africa. So right after I finished finals, I got off on a plane, and to Africa I went.
Where in Africa?
Kenya.
Wow.
So we were in Nairobi, and then in the Kipsigis tribe out where I was living in a dung hut for 8 weeks teaching mandatory religion classes through a Swahili interpreter. So it was really just a phenomenal time, and a lot of children. And I loved kids.
Was Andy with you?
No, we didn't meet till I was 35.
Wow.
Yeah, and then married at 37 and had our 3 sons all at once, triplet boys, just shy of 40. However, okay, so I'm back in Africa, and it was this particular moment, and I had been with the missionary who was there, and we ran out of gas. So she went to go get gas, and I was sleeping in the back of this Jeep, and all of a sudden the Jeep starts like rocking back and forth, and I'm like, and I realized it's like 50 little kids trying to look at the white girl, you know?
It is like that in Africa.
So long story short, we end up, after I get out of the Jeep, first we played like soccer with, it's so quintessential, like what you would imagine. It was a ball of tape, like tape and tape and tape, instead of a soccer ball.
Yeah.
So we did that for a bit, of course, not speaking to each other, really just laughing and pointing. We're sitting in a circle in one of their homes, which had no furniture. We were just sitting in a circle, and I was balancing potatoes on my head, just trying to make them laugh, because their moms, of course, like balance potatoes for a mile up high and can run a 10K. And not drop any of them. Meanwhile, I couldn't get like 2 potatoes to stay on my head. And then boom, that just hit me. Like there was such joy, such laughter, such love in that room that could only be made more magnificent by health, right? Like here I was in a place that had very little running water, and having a toothbrush was a luxury. What I wanted to spend my life doing, because it kind of just came together in that moment, was helping people stave off the #1 killer of joy in life, and that is being ill. And so I heeded God's voice, and I came back, and boom, transformed my whole curriculum to be pre-medical, and the journey took off from there.
And were you vegan at
Oh
that
gosh,
point?
no. Okay, so then, fast forward 20 plus years, and I'm writing Breast, the Owner's Manual. In 2017, I wrote this book. It came out in 2018, and I was deep diving into nutritional science. So you get 0, zippo, none in medical school, except to learn how ATP is generated, like energy, right? So whether it's because you get no nutritional training that we think it doesn't matter as grown-up doctors in the real world, or it's because we ourselves have just never gone into the literature to find out otherwise.
Yeah.
It's a combination, right? Because you don't get any training in school and you're becoming a doctor, by silence, you just somehow assume, well, there's nothing there. There must be nothing about the food that's so transformative that you would use it as if you would use medicine, right? Mm-hmm. Otherwise, you would have heard about it. So here you are in your practice, busy doing what you do all day long, and when you go home at night, you're not going to pick up a nutrition journal looking for pearls of wisdom that you don't even think exist so that you can go dispense them the next day. You know, you're going to go home and exercise or eat dinner or see your kid. You know, you're going to live. Mm-hmm. So here I am now deep diving into the literature because I have to. I'm writing this book and I want to be factually correct, evidence-based, and I dove into the literature really just to prove that I was right, which was like the way I ate, which was kind of Mediterranean diet style, lots of fruits and vegetables, lean meats, chicken, turkey, fish, like so much. Andy and I ate sushi, I would say 3 to 5 nights a week, like unabashedly radioactive, didn't care. Never wanted to check my mercury because I didn't want to know.
Yes. So I was the same way.
Right. So the other thing, being a product of the 80s in high school, was that I was deathly afraid of carbs. So pasta, rice, potatoes, bread, ixnay. Like that was birthday only, right? So very low carb, and except for the fruits and veggies and then these meats. And I went into the literature to prove that that is how you're supposed to eat for optimal health. Whoops. A little bit in error there. And it was after about 3 straight weeks of looking into all of this science behind what animal protein and what animal fat do to you inside your body as a cellular response, skyrocketing estrogen levels, making growth factors go through the roof, hitting the immune system, creating angiogenesis, blood vessel genesis creation, right? The creation of new blood flow to these sinister little cancer cells that then get the nutrients they need not only to grow, but they just created their exit strategies straight out of the blood to your liver or bone. So overwhelmed by these clear processes that happen inside the body, I was equally stunned by the power of plants to utterly stop, prevent, reverse those same processes inside your body.
That's beautiful.
So I'd had enough of it one day, walked downstairs, briefly talked to Andy, who was like completely on board.
Wow.
Oh yeah, he grew up in Germany and his mom was always very progressive and had a very kind of clean diet, but not vegan, right? So I'm like, boys, they'd just turned 8 at the time. And I open our fridge and I'm like, I look at it and I see this like $50 salmon fillet I just bought for the Sunday barbecue that was going to be the next day.
Oh, no.
And then I have my therapy drawer. It was like literally had a sign. Okay, not literally, but everybody knew.
Yeah.
Mommy's therapy drawer, do not touch. And it was filled with like 5-year-age Gouda and Manchego and Brie, right? All like my expensive cheeses.
Yeah.
And just got it all into bags. 4 bags filled to the brim. I am the product of parents who are in their 80s, so they are depression babies, right? They grew up in the 30s and waste not, want not. You do not throw that, like hundreds of dollars. And so my parents luckily just live a mile away. So I'm like, come on, guys. We go and bring the 4 bags of food. I'm like, here, Mom and Dad, it's too late for you.
Oh, no.
Which, for the record, I do not believe that it is ever too late.
Yeah, that's true.
They are not plant-based. I'm trying to get them to eat more and more so. My dad has memory issues, be it Alzheimer's or dementia. And
oh boy.
We're not entirely sure, but the point is, I do believe that eating plant-based would help stave off further progression of that. Literally in a day, we went 100% whole food plant-based, never looked back. I've never cheated. We started off, I told the boys, like, you can have a cheat day. And they had like 2 days, and then they were done, and we were done. We're like, I don't want the chicken for the reasons of health. Mm-hmm. My eyes were wide open to animal cruelty and how horrific factory farming is. And my eyes were wide open to the massive contribution that animal agriculture makes to the destruction of our planet and to climate change and to just overall global inequity when it comes to access to food. There would be no hunger in this world.
I know.
And we watched a few documentaries to cement those facts in. And the boys were on board right away. Yeah.
So special.
Yeah.
And I met them. What are the different types of breast cancer and which ones should we be most concerned about? Also, what are the different stages?
So there are about 21 different types of breast cancer, but they, for the most part, begin in the milk-producing lobules of the breast, which you can imagine holding up a bunch of grapes, right? So you've got a main stem and then all these little stems going back and back and back. Those would be milk ducts.
Okay.
And they end up at the grapes, which are the milk lobules. So the lobules make milk, the ducts carry it out and through the nipple. And if you take one of those bunches, right, you've got one stem here, that's coming out the nipple. But as you go back and back, you've got like 100, right? So we've got about between like 10 and 15 of these groups of grapes that are then coming out. So 75% of all breast cancer starts in all the little stems, the milk ducts, and about 15% starts in the lobules, and then 5 to 10% is weird stuff in the stroma and supportive structures of the breast itself.
Okay.
Most of the unusual tumors at the end of the day are also starting in ducts. And what really defines a cancer is its inherent biology, its ability to actually exit the breast. Because no one dies from breast cancer in her breast. It can even make it to the lymph nodes, and you'd never die if it just stopped there. Because both the breast and the lymph nodes that they travel to under your armpit are not vital for living. What matters about breast cancer is, does it go to an organ that you cannot live without, like bone, liver, lung, or brain, which are the four most common places breast cancer goes. So what is the inherent biology, the genetics of that cancer, not of you, but of the tumor? And in those genetics, what is the potential for that tumor to spread? So the cancers that are most likely to spread, and therefore the ones when you asked which ones should we be most worried about, are called inflammatory, which is a type of cancer that is hard to diagnose because it oftentimes doesn't form a lump that is felt by a person or seen by a mammogram. And what you want to watch out for is a suddenly enlarged, red, swollen, tender breast where the skin has this, what we call podo-orange, peel of an orange. It has like that same hue of an orange. And then like the little pock marks, the dilated pores, you see them. So the skin looks kind of swollen.
Interesting.
There may or may not be a lump under your armpit with that condition. So inflammatory is basically an emergency. It's often misdiagnosed initially as an infection, and after 3-4 days, if the antibiotics you started are not clearing up that redness, hightail it to a doctor because you may have inflammatory. The other two most worrisome types are triple negative. So triple negative means that there are 3 receptors that may or may not be on the outside of a cancer cell are absent in triple negative. So the 3 are estrogen receptors, progesterone receptors, and HER2 receptors, which is a growth factor. So you can think of a receptor being like a little antenna sitting on the cancer cell, and let's say we're talking about estrogen. So when estrogen hits that receptor, it will send a signal to the cancer cell to multiply and divide. And actually, while that sounds like it's not such a hot thing to have on your tumor, we love estrogen receptors. Number 1, they're associated with less aggressive cancers. And number 2, now I know that you're fueled by estrogen. I can aim some anti-estrogens at that receptor or at you as the woman with breast cancer so that your cancer fuel is gone, right? So those women ultimately have less recurrence and death than the estrogen negative, so meaning no receptor. So the triple negative, no estrogen, no progesterone, no HER2, is generally an aggressive cancer that needs to be treated aggressively. And because there's nothing to aim at with receptors, we almost always throw chemo at that person because chemo has one goal in life. What around here is moving fast? Oh, that triple negative cell is. So it annihilates it. So the kind of bittersweet good news, bad news about triple negative is it's aggressive and not the easiest cancer to cure. However, when we cure it, we like, bam, cured it because it's kind of all or none. Within 3 to 5 years, if you're triple negative and it didn't come back, you're golden. It's not coming back because it will come back quickly. Whereas the estrogen-driven ones, they kind of plod along and may or may not recur, but when they do, it's often 10, 15, even 20 years down the line because they're slower growing. The final tumor that we worry most about is one that is HER2 positive. So we used to worry a lot about it because it was very aggressive. However, about 18 years ago, a missile of a drug called Herceptin was aimed at that HER2 receptor and became so precise and so highly effective at getting rid of tumors with their HER2 receptors. That as long as you go through the treatments, which include chemotherapy along with the HER2, and if you have estrogen receptors, so we can also aim anti-estrogen stuff, this formerly highly fatal cancer has literally become the best prognosis of all tumor subtypes.
Whoa.
Right.
Well, hopefully that gets to be, triple negative. You can say the same thing
I
about
know.
other ones too.
I hope we can. You asked about staging.
Yes, what are the stages?
Breast cancer is staged 0 through 4. So in situ cancer means that so let's take one of those milk tubes that we were talking about, when it should have a single cell lining where each cell is very uniform and orderly, one to the next. And when the cells start to get a little bit atypical and they're heaped up on each other and disorganized, they're growing without control or order. But if they're just packed inside that tube, they have no access to the lymphatics or bloodstream. So that's what's an in situ cancer. The tube wall is intact, but the cells inside are cancerous. That is, stage 0 is entirely curable, and you never need chemotherapy to cure it. And depending on your choices, you don't need a mastectomy to cure it. So stage 0 is the best. And then 1 and 2 have to do with the size of the cancer and whether or not it went to lymph nodes. And then if it did go to nodes, how many? And so once you pass 4 or more nodes, you're moving towards stage 3, except it's still all contained in the breast or the nodes. And stage 4 is when we've identified it out there in liver, lung, brain, or bone.
How much of breast cancer is actually from genetics and family history? And do you recommend taking any genetic tests? If so, which ones?
This is my favorite question that you could have possibly asked, because
Yay!
the answer is going to shock you. And that is that a mere 5 to 10% of all breast cancer on planet Earth is attributed to an inherited genetic mutation that you receive from either your mom or your dad.
Very low.
So let's flip that number. 90 to 95% of all breast cancer on planet Earth is not from genetics. So what is it from? And this is the beautiful truth. It is from the daily choices that we make. Every single moment that we live fork to mouth, meaning our diet and nutrition matters, our decisions about exercise, alcohol, obesity, taking hormone replacement therapy, emotional stress, environmental toxicities, all of these collide inside of a woman in different ways to either manifest a cancerous change or to promote health. So when you ask about genetics, it is important, it matters, and if you do have an inherited genetic mutation, for the most part, probably all of your best intentions might not outwit that mutation, because you're kind of handicapped in that way. Although even some evidence and studies are changing that notion. And
That's exciting.
It is exciting. And some of those things are food. So the people who should consider genetic testing are anyone who has had a breast cancer herself under the age of 50, or if she has 2 relatives. Now remember, mom or dad's side, you're half your father's DNA. So there's a myth out there promoted by even some doctors who just don't remember that your father can hand you down a genetic mutation that has a connection to breast disease. Just because he's a man and we think women for breasts, that doesn't mean that mutation. Okay, good. So mom and dad's side, first, second, and third degree relatives, so literally your grandmother's brother, did he die of pancreatic cancer? We want to know that, because if you have 2 relatives on the same side with breast cancer prior to age 50 or ovarian cancer at any age, you have a greater than 10% chance of carrying a gene mutation. If you yourself have had breast cancer prior to age 50 or a cancer in both breasts at the same or different times in your life, if you've had a triple negative cancer, which we just discussed is a not as common as others and also a highly fatal subtype. If there's a known genetic mutation in the family with a direct blood link to you, then certainly you should consider testing. Any men with breast cancer in the family tree. And then finally, just a whole lot of cancer going on, specifically breast, ovarian, pancreatic, prostate, colorectal, uterine, and melanoma. So all of those people definitely should test, because if you fit on that list, you have a 10% or greater risk of carrying a gene mutation. However, I believe anyone who just wants to know if she or he carries a genetic mutation should test, because the testing has become extremely affordable. So the list I gave you is the general one used by insurance as their criteria to pay for the testing.
Okay.
It used to be prohibitively expensive, literally $4,500 to find out if you carry these gene mutations. It's come down as low as 199 to find out about 30 different gene mutations.
Well, I just took one called 23andMe. Do you recommend that one to
No. So
patients? No.
Yes and no. 23andMe is only looking at BRCA or BRCA mutations, and it's only looking at 3 of them. Like we have about 1,000 that we know how to find. The 3 that they're looking at are the most common. However, they're called the founder mutations and are most prevalent in the Ashkenazi Jewish population. So I should say that if you're looking at just BRCA, all of us running around Earth have a 1 in 500 chance of having a BRCA mutation. Just by being of Eastern European descent and Ashkenazi Jewish, it's 1 in 40.
Whoa.
So that list does narrow that I gave you. You'd really just need one relative with breast cancer under 50 or ovarian at any age if you're Ashkenazi. The 23andMe, so it just looks at the 3 founder mutations, but it's extremely interesting because it gives you your ancestry, right? You figure out like what percentage you might be Ashkenazi or African American or Hispanic, et cetera. So it's an interesting test. I'm not saying don't do it, but it's not going to give you the answers about genetic predisposition.
In your opinion, how much do you think diet impacts the development of breast cancer? Can certain foods turn on and off genes when it comes to breast cancer?
In my opinion, diet has everything to do with breast cancer. Not in isolation. It does work in concert with other things like whether or not you're overweight, how much alcohol you consume, which is partly diet, and environmental toxicity. I think emotional stress and a lack of psychosocial community support and love in your life, all of it matters. But I think the big daddy actor is your nutrition. And the reason I think that is that food holds the power within it to create the environment that tumor cells require to come into existence and then to grow and develop and then to metastasize and cause you fatal harm. Conversely, plants inside of them contain phytochemicals, right? Phyto meaning plant, and chemicals. They have a number of very chemical sounding names: the sulforaphanes in broccoli, the curcumin in turmeric, the epigallocatechin gallate in green tea, the anthocyanidins in apples. So we've got these chemicals that to you, you're just chewing and swallowing a broccoli floret. But that isothiocyanate mixes with myrosinase, the enzyme in the cell wall. Don't fall asleep. And
This is fascinating.
that becomes sulforaphane. Sulforaphane literally gets into your bloodstream, courses through your veins, saturating your cells with the ability to seek out and destroy cancer cells. That is what that floret becomes inside your body. So you can bet your life on the fact that food matters. And the foods that fight the most are all plants. And amongst the plants, the foods that fight the best are the cruciferous vegetables, so the broccoli and Brussels sprouts and leafy greens like kale and spinach, and berries. Berries have magnificent powers, as do onions and shallots and mushrooms. I mean, I really could go on and just name an entire produce section. Once I get started in my head, I'm like, well, if I'm going to name the mushroom, then how can I leave out squash? So, just eat plants.
Eat plants. It's easy. Keep it colorful.
Well, yeah, and why do you say so? Keep it colorful matters. The most potent part of the plant is the skin, where the color is, because the color is made up of the phytochemicals. So the more of a rainbow you have on your plate, the more of an arsenal of weaponry against disease you have coursing through those veins that we just talked about.
I like that. When we do eat a whole food plant-based diet, can our blood act like a chemotherapy?
So when we eat a whole food plant-based diet, your blood can absolutely be transformed. Will it be as potent as chemotherapy? Yes and no. You asked if food can turn on and off genes. It absolutely can. Dr. Dean Ornish masterfully showed this in men with prostate cancer. And just by eating a whole food plant-based diet and other healthy lifestyle behaviors, he showed that over 450 bad genes got turned off and like 50 good genes got turned on inside the body within hours to days. This isn't a long-standing effort that you need to make to sustain the benefits. So when you eat plants, one of my favorite studies, because it really shows women, when I'm talking to a cancer patient who's like, okay, I hear what you're saying, doc, but it's too late for me. Like, look, I've already got this stage 3 cancer, and I've just done it wrong for too long. I'm like, not so fast, sister, listen to this. So there was this study where they took 50 obese women, and they did two main things. They took their blood to measure a bunch of stuff, chief among them IGF-1. So insulin-like growth factor is the big daddy of all inflammatory creators inside your body. And your brain's smart. It knows when you need IGF-1 because it's actually a useful thing to have around. It kind of like makes you breathe and heals a cut when you're cut open, brings inflammation to the area to heal and repair it. It helps post-exercise muscles recover from a good workout. But in excess, it's a growth promoter. That's what it does. It makes you grow. Super useful when you're 12 and need to become 22 and grow up. Super harmful when you're already fully grown and you have an excess of IGF-1 screaming at everything, grow, grow, grow. Okay, we've already fixed the muscles from exercising. We've already turned over the stomach lining from we turn over 50 million cells a day, so they need repairing and regenerating. Thanks, IGF-1. But in excess, it's still running around. Grow, grow, you grow fat, you grow plaque, so you get Alzheimer's and a stroke and cardiovascular disease with a heart attack. You grow abnormal cells in your pancreas, type 2 diabetes. You grow into a breast cancer cell. You keep growing, metastasize into the liver, right? That's IGF-1. Okay, back to our chubby ladies. We got IGF-1 drawn, and then IGF binding protein. So it's like a little body snatcher that retires the IGF-1 from circulation. And they took their blood, dripped it on a petri dish full of human breast cancer cells. A few cells died because everyone has a little anti-cancer flying around. These women go away for 12 days, okay? That's the key to my lady in front of me. 12 days, they go away. They do two things: a whole food plant-based diet, and they exercise for 30 minutes a day. For most of these women, we're talking like sauntering around the block, okay? Mm-hmm. They didn't like pump iron and do some crazy workout. 12 days. Drew the blood again. IGF-1 levels had plummeted. Binding protein had soared. Dripped the blood on the petri dish, and the majority of cancer cells died on the spot. So can you transform your blood by a meal into chemotherapy? Not exactly, but kinda.
Does drinking alcohol contribute to breast cancer risk, and does it increase estrogen levels in both men and women?
So drinking alcohol does increase estrogen levels in both men and women. It creates acetaldehyde, which is a carcinogen, even if you just used it as mouthwash. So just like swish and spit, you've already created this carcinogen that you swallow down. Alcohol impairs the immune system. So small violin, yes, alcohol is a carcinogen. The doctor in me has to be really clear about that. The safest amount of alcohol to consume is 0. One of the main reasons why alcohol leads to cancer promotion is not necessarily the hit to the immune system or the estrogen level bump. It's the inactivation of an enzyme called MTHFR. This enzyme is converting folic acid into methylfolate. So the active form of folic acid runs around and fixes DNA when it goes awry. But if you drink often, or if you're one of the 40% of human beings whose MTHFR isn't entirely inactivated, but it's slow, doesn't work right, and then if you drink on top of it, the double whammy, that enzyme's just not working. So it's not converting and you're not getting methylfolate. In the Nurses' Health Study 2, which was a very large study of 89,000 women followed for many years, when they pulled out the subset of just drinkers, so now we're just talking people who drink, those who consumed green leafy vegetables and more folic acid and then methylfolate through these vegetables, had 89% less breast cancer than those who didn't consume it.
At what age should we first start getting breast exams, and how often after that?
What a great question. So I differ from the main guideline. The main guidelines are that you should start getting breast exams about age 20 and get them every 3 years. And then when you hit 40, get them every year. Here's what I think. You should start doing self-breast exams when you get your period. It's not because I want a 12 or 13-year-old to worry that she could have breast cancer right now. I want her to familiarize herself with her breasts. The terrain is kind of lumpy and bumpy, and it can wig people out if they just start doing self-breast exams at like age 45, because it all seems like it could be cancer to them. But if you're with your breast all day and all night, forever, so you should just know how they feel. So doing a dedicated self-breast exam at very young ages when your breasts are developing and beyond, it just breeds this familiarity that's unconscious to your fingers, like a finger memory of the hills and valleys of the breast tissue terrain. And so, knock on wood, but if anything should ever grow, you don't even have to wonder. You just know, that was not there last month. So I advocate for self-breast exams as soon as menstruation starts. But I do think you should start visiting your doctor once a year, every 3 years, starting at age 20, every year thereafter, every year once you hit 40, and forever thereafter.
And then what about mammograms? How old should we be and how often?
If you are at normal risk for getting breast cancer, there are different societies that advocate for different timing of mammography. Some say start at 40, others 45, others even 50. Some say go every year, others say every other year. Some say stop at age 74, others say do it forever. I want to make 2 points. One is that 20% of all breast cancer happens prior to age 50. 20% of all breast cancer happens after age 70.
Whoa.
So the bulk, the 60%, is between ages 50 to 70. To me, not the time to start doing your mammo every other year. That's your bell curve, right? But to the women, the 20% who are under 50, prime of life. There's never really a convenient time to get breast cancer, but it's especially inconvenient and scary and more likely to be one of the more aggressive subtypes when you're under 50. So 5% happens under 40. That's really kind of outlier weird stuff. I'm not even sure how much diet and lifestyle have to do with that 5%. However, we've got now a 15% group, 40 to 50 years old. Why are you starting mammograms at 50? I want to start them at 40. And I say, don't stop and don't skip until you plan to die in the next 5 years, which is a hard thing for you to predict, I realize. But that is the official stance of the American Society of Breast Surgeons and mine as well. Because at the end of the day, these other recommendations come down to a cost-benefit analysis. So the cost-benefit analysis of whether or not to get mammograms has to do with much more than money, although money is one of those factors. It also has to do with the anxiety associated with a false positive. So we say, we think we see something. It might be nothing, but why don't you come back? And oftentimes they say, we have time in a week and a half. So for a week and a half, this woman spirals in her mind to the worst case scenario of who's going to take care of my children because I'm going to die next month. And psych, 9 times out of 10, that callback was for naught. It was benign. Of course, you're grateful, but you're like, really?
Yeah.
That was a heck of a week. And that callback still might lead to, there's definitely more radiation with more views, maybe a biopsy. 9 times out of 10, the biopsy is benign. We're thankful for that. But really, did I have to go through a biopsy, the expense, time off work, child care? It kind of compounds itself, right? So there is a cost to excessive screening with the question of, is this extra screening going to save lives? And the answer then becomes very nuanced in terms of, what do you think is worth a life? Which is really what we're saying. So, for example, when the U.S. Task Force came out with their recommendations to begin mammography at 50 instead of 40, basically, in the years between 40 and 50, you'd have to do 1,900 mammograms to save one life. But once you hit 50, you only had to do 1,300 mammograms to save one life. So in whatever kind of statistical analysis they were using, 1,300 seemed worth it, and 1,900 too many. So they said start at 50. It's not wrong, but it is what it is.
Yeah.
And that's the whole thing about mammography. It's not that we found out that there's more harm than good from screening more often. There are arguments on the flip side, though, and we could go through some of the, we find a lot of cancers that probably don't matter, meaning you never would have died from this cancer, so did you really have to know about it? Because now that you know about it, you're probably going to treat it, and that treatment comes with a lot of toxicities and or just damage to your breast and your life, and now you're on an anti-estrogen for 5 or 10 years. A lot changes that doesn't lead to a longer life, but no one has the cancer diagnosis doesn't also come with the crystal ball. So we don't know. We're doing that whole inherent biology, the look into the cancer sneak peek to see how bad the biology really is, and therefore how much treatment we really have to throw at you to stave off a metastatic recurrence. If you screen 10,000 women, as I suggested, every year from 40 up, you will cause 8.6 cancers, breast cancers, that never would have happened, but you will find 860 cancers. So mammography finds 100 times more cancers than it causes. But for those out there who say, well, I don't want the radiation because it causes cancer, you are correct. Mammography does cause cancer. But it's what we've got right now.
What are the drawbacks to imaging and mammograms?
So one thing to know about your mammogram is whether or not it sees your breast tissue as dense. So we grade density A through D. C's and D's have more dense breast tissue than fatty. So dense tissue on a mammogram looks white and splotchy like a snowstorm. Unfortunately, cancer on a mammo is always white. So now you're looking for a snowball in a snowstorm. And in our C's and D's, our dense breasts, we miss 30 to 50% of breast cancers because of that problem.
Oh boy.
So if your breasts are dense, I always advocate for adding whole breast screening ultrasound to your annual screening. If you are at elevated risk for breast cancer from having a gene mutation or a strong family history of breast cancer, or you've had a breast biopsy yourself that has like the whisperings of precancer stuff, then you want to think about adding MRI. Breast MRI is our best look into breast tissue. However, you might not want to do it every year because talking about drawbacks of stuff, the gadolinium, which is a required dye to shoot into your vein in order to see the breast, like you can't do it without the GAD, has been found in autopsy studies to pool inside people's brains. So not everybody's brain, and we don't know what it does there if it causes any harm. It's not like those people all had Alzheimer's or something. But now they've changed the formulation of gadolinium since about 2016, but we don't have the studies to prove that it's totally safe and it doesn't pool in the brain, so.
You say something pretty shocking in your book. When treating invasive breast cancer, removing your entire breast does not add one more day to your life as compared to keeping your breasts. Removing the breast with mastectomy or keeping the breast with lumpectomy, with or without radiation, yields identical breast cancer survival rates. So why even get mastectomy?
Great question. So 6 different international studies in the 1980s proved that point over and over and over. All 6 showed the same thing. In other words, survival is not impacted by whether you just pluck the tumor out of a breast, lumpectomy, or do that lumpectomy and then radiate the breast in some fashion to sort of sterilize straggler cells, or remove the entire breast, which I have to say kind of diminishes my entire life's purpose as a breast cancer surgeon. It doesn't matter what I do, you're gonna live or die anyway. But the reality is simply this, and we touched on it earlier. Nobody ever dies from breast cancer in her breast. The breast is not an organ necessary for life. So in other words, at the moment of diagnosis, you either have cells flying around in that bloodstream that are destined or not. With the power of plants and other healthy lifestyle behaviors, we can change the soil out there so that it's inhospitable to those floating cancer cells, okay? So shock of shockers, back in the 1970s, a study looking at mice from the NIH grant wanted to look at this fact, like do tumors shed cells into the bloodstream? So they implanted breast cancers into little mice and did blood draws every so often. And what they found is that, at least in mice, 3.2 million cancer cells are shed into the bloodstream every 24 hours. Once it hits the stage of an invasive cancer, right? No longer in the duct, broke through the duct, invasive. So back to this big study that's so shocking. If you think about it now, we've got a shedding of cells out into that bloodstream every 24 hours. And whether now I take the cancer out, radiate the breast, take the whole breast, like, that doesn't change the fact that those cells are out. They were out last week and last month and last year probably. So it now becomes a question of how effective are the treatments that you're going to sustain and the lifestyle behaviors you're going to alter. How effective will they be at staving off a metastatic recurrence? And it no longer matters about the surgery. Why would you ever take your breast off then? Well, here are 4 good reasons. 1, big tumor, small breast, or the ratio is such that to remove the tumor leaves you with like some sort of not breast-shaped thing that you're probably gonna then radiate. So size of the tumor, number 1. Number 2, an interest in avoiding radiation. So although survival doesn't change, recurrence rates, meaning the cancer coming back again, locally right there where the tumor started or in the lymph nodes, that will go from something around 40% if you just take the tumor out to about 4% if you radiate. So radiation is a very attractive option for people who want to keep their breasts, except for people who don't want radiation. So if you don't want radiation, you might choose a mastectomy just to drop down to 4%, which is what you'll do, without the need for radiation. Third person has a gene mutation. So someone who, say, has a BRCA1 mutation, now that she has breast cancer, has a 65% chance of getting yet another breast cancer in her lifetime in either breast. So that person will probably, depending on her decision and her age, decide to remove both breasts. And finally, the person who does a mastectomy, even though it doesn't increase survival, is someone who just wants it. And that is the most common reason for which I do mastectomy. It's someone with cancer who's like, it doesn't matter what their thought process is, but oftentimes they're young and they don't really feel like they have a good reason, they don't carry a genetic mutation, or everybody in their family has gotten breast cancer, and even though there is no gene mutation, it's just a fait accompli where there probably is a mutation we just don't know how to test for yet, or none of the above. She's just like, my breast turned against me and I don't want it anymore. Like, it's my breast and I don't want it. And that is a very legitimate feeling and reason to proceed with mastectomy.
Okay. Can you develop breast cancer recurrence after mastectomy?
You can develop a local recurrence in the skin or in the armpit lymph nodes. Even in the best of surgical hands, you can't scrape the skin of the breast clear of every last cell, because in so doing, you would be taking all of the lymphatics and blood flow and the skin would fall off. So you can, and that rate is somewhere around 4%, but if you have an estrogen-driven cancer and you take anti-estrogen pills, it's more like 1% to 2%. So they're low numbers, but they are not zero.
When getting a mastectomy, can one keep the nipple and skin around the breast and then get implants after? Will leaving the skin and nipple leave any risk of breast cancer recurrence?
So depending on your breast size and where your tumor is located, it is absolutely possible to keep the nipple and the areola and as much of the outside skin as we can, or all of it. So it really comes down to the cosmetic outcome that we're desiring. All of the A cups and B cups out there are pretty easy to, well, it's not this easy as a surgeon, but if you make a little cut like where an underwire of the bra sits, and then you just lift up all of that skin, the nipple, like everything is one big piece, breast out, implant in, skin down, the incision's underneath the breast, and the outside is just you. Kind of, if you've ever been pregnant or nursing, it's like that vision of you. Like everything's a little perkier, fuller, higher, but your freckle, your nipple, your little scar that you may have gotten, before, it's all you when you look in the mirror. And very similar to how you've remembered your breasts because you're a smaller breast cup. When you get into your C's through F cups, everything's a little bit droopier and lower, and so it's more challenging to get that nipple in the center of a reconstructed breast. But I love doing it. I mean, I'm up for the challenge. We've got lots of tricks, surgical tricks to achieve that. Can you safely keep the nipple? Absolutely, when you can. So if the tumor's not in the nipple, you can keep the nipple. And we specifically test the ducts inside the nipple as a separate biopsy to prove that nothing precancerous or cancerous is brewing right there, so that the other part of the nipple with the end of the ducts can have tumor in it if the lower part did, right? So in that situation, you take the nipple. A 2014 look at all of the studies doing mastectomy keeping nipples showed a 3% recurrence rate. And not in the nipple itself, just across the board, 3% recurrence in the skin or in the nipple. And those recurrences, when they happen, are essentially always in people who had cancer in that breast. Okay. So the prophylactic mastectomy is keeping the nipples, meaning there is no cancer there, we're just removing the breast maybe because of a gene mutation or the other side had cancer. So the prophylactic mastectomy cancer rate in the nipple really should be 0.
And what are some alternatives to surgery, chemo, and radiation? What are your thoughts on targeted drug therapies and immunotherapy? What are they, and are they safer and possibly more effective?
So there's a difference between alternative therapies and complementary therapies, and there's a difference between alternative in exclusion of the tried and true, like chemo and surgery. When you're talking about solid organ disease, right, like a breast cancer, colon cancer, liver cancer, uterine cancer, these are wads of invasive tumor that are always best treated surgically. Like just get the wad out rather than like trying to aim broccoli at it, right? So once someone has an invasive breast cancer, I never advocate for solely alternative-minded therapies. I aim for complementary. Bring it all. Like,
Yeah.
the life is in question here. Like, let's do everything we know safely. Now, surgery alone gets rid of like that wad of cancer. Chemotherapy is aimed at out there. The potential, it could be, if it's already stage 4, the reality, but we're usually not stage 4. So we're aiming at the potential for cells flying around in the bloodstream to land somewhere life-threatening. And chemotherapy is aiming to annihilate those cells before they have that chance, right? So a large percentage, we're never going to do that anyway. The benefit of chemotherapy at its best in breast cancer, well, not as best, as an average in breast cancer, is dropping that chance of something happening by about 10%. So there was already a high chance that it was never going to happen anyway. So now you get people running away from chemotherapy that was advised and then not having a recurrence 5 to 20 years later and saying, see, I cured it. Which may be true. I'm the last person to say that dietary and lifestyle interventions don't alter the path of your health life. They absolutely do. However, that one person can't prove that they stopped the metastatic recurrence because it wasn't there and then reversed. Now, those people have a story to tell. If they have a wad in their tumor and their interventions took it away, that's a different claim.
Have you ever seen that happen?
I have not. Alternative therapies are not immunotherapy and other targeted biological therapies that are coming down the pike and here now for breast cancer are very exciting. I wouldn't label them alternative, though. Just in people's minds, alternative kind of means off the beaten Western medical path.
Okay.
So what they are is just in addition to or instead of needing the chemo. So immunotherapy, far and away, to me, is the most exciting advance. In fact, the Nobel Prize in Medicine was awarded in October of 2018 to 2 immunotherapy scientists who are looking at, it's phenomenal. So what you're doing is you're potentiating your own immune system, right? We have these cells whose entire job is to survey the land for dead and dying cells and for sick cells and for deranged cancerous cells and to either fix and repair stuff or to get rid of it. So what if you could give your body something that just heightened the ability that's already innately there? Immunotherapy is brilliant. In 2018, it was shown for the very first time, the very first drug to ever show prolonging the life of a stage 4 triple negative breast cancer group. Immunotherapy was the key. So what happens with these drugs right now is that you've got 2 handicaps. One is that the tumor itself has like this black mask over it. So your own immune system just passes by it, doesn't see it. And your immune system has a blindfold, so it doesn't see well anyway. Enter immunotherapy drugs, and what it effectively does is it pulls off the black mask and it takes off the blindfold. So now chemo could see this more effectively, so can your immune system. So immunotherapy is usually given with chemotherapy, so it's not really a or, it's a with.
What are your thoughts on hyperbaric oxygen therapy?
Hyperbaric oxygen therapy helps with healing. I don't think it's a standalone treatment for any cancers, but I use it frequently.
Do you?
Oh yeah, I definitely with the skin recovery after mastectomy. It really boosts the oxygen and blood flow to the skin.
Nice.
And can help. But as a therapy for breast cancer, no.
What are the most common places breast cancer metastasizes to? How does one prevent this, and can it be stopped with diet and lifestyle?
So the most common places breast cancer likes to go are bone, liver, brain, and lung. You want to think of this whole cancer world, breast or otherwise, as seed and soil. So some sort of cancer-promoting carcinogenic action or a collision of multiple actions has happened inside your body to allow a seed, a cancer cell to form. So when it comes to cancer, we don't like this blossoming of tumors into these one seed becoming an actual cancerous mass that can then flourish elsewhere in the body and shut that organ down. So in other words, soil. These carcinogenic things can ignite a seed. Seeds don't matter. What matters is what is the condition of the soil in your body. We need to nourish and cultivate and create an environment that never allows cancer cells to thrive. If you think of a breast cell going to the liver, think of yourself going to Italy. You're still an American in Italy. You're not suddenly Italian, right? Same story. It is a breast cell. The liver environment, it's not its home turf. It takes a lot for the liver to be like, oh, come here, little breast cell, grow and flourish here, and now take me over and shut me down, right? So what you want is for the power of plants and healthy lifestyle behaviors to create an anti-angiogenic environment. Remember back to what we were talking, blood vessels are a number one must-have for that cell, that cancerous cell, to survive and thrive. So food is anti-blood vessel formation. It is anti-estrogen, which is feeding and fueling 80% of the breast cancers. It is anti-IGF-1, anti-growth factors that it requires to get the fuel going that it needs to continue growing. It is anti-inflammation. So the cancer cells fuel on inflammation, fuel on glucose, fuel on your HIT immune system. So the more you do in your life that takes away all of the things that those seeds need to multiply and divide and then thrive, the more capable you are at staving off a recurrence and of healing thyself.
Babies and breast cancer. What if one develops breast cancer while pregnant or right after giving birth? Can she still breastfeed? Should one produce milk from radiated breasts or medicated bodies?
So breast cancer during or immediately after pregnancy is always devastating because it is the quintessential bitter sweet, right? Like nothing could be worse than hearing you have breast cancer. Nothing could be more beautiful than having just birthed a baby into the world. Unfortunately, when that happens, you usually cannot breastfeed because you're going to be straight into the throes of medical treatment. Kind of depends though. There are workarounds for sure. So the short version is when you are in your second and third trimester, we can operate. So depending on how big the tumor is, we either do a lumpectomy or a mastectomy. You're not going to get radiation while you're pregnant. So we can get rid of the tumor, and if you need chemotherapy based on the biology of the cancer, that also can start while pregnant in your second and third trimesters. Certain chemo agents that are effective against breast cancer are thankfully not harmful to the in utero fetus. There are a couple of drugs that are, and if you need those because of your cancer subtype, we wait until the delivery of the baby, and then you move on to that bad actor. But some cancers won't need the bad chemo. Some cancers won't need chemo at all. So they just needed the surgery. And so once you deliver, you can get radiated to the cancer breast, but your other breast is fully functional and producing milk. A radiated breast will not produce breast milk. So in certain women, you can decide to breastfeed from the healthy breast while still treating the cancerous breast.
And what if you get a double mastectomy? You obviously can't breastfeed, so you just have to do formula, or maybe get a donation from some other situation.
Right.
Okay. All right. Well, I'd like to end on my favorite inspirational quotes from your book to possibly inspire and give some hope to those searching for it. You say, finding a faith community to be connected to and to be altruistic towards others reminds us that we are not meant to carry the weight of the world alone and are meant to be part of a whole. Being religious and spiritual elicits feelings of optimism, comforts existential fears, elevates self-esteem, creates an internal locus of control, and reduces anxiety. The number one cause of anxiety is the future, and the future doesn't belong to you. It belongs to God, and it might be better than you think. Thank you so much for existing in this world and doing everything that you're doing. God bless you and your family.
Oh, God bless you.
Thank you.
Thank you for interviewing me.
Thanks so much for tuning in.
Love, Gianna and Dr. Funk.